My name is Sven Poli. I'm very happy to have this great opportunity to present some slides of the presentation of the PROOF trial that was shown at the World Stroke Conference in Toronto. The PROOF trial aims at saving penumbral ischemic tissue by normobaric oxygen therapy in acute ischemic stroke. These are my disclosures. So the trial was funded by the European Union with nearly 6 million euro. And the academic sponsor was the University Hospital of Tübingen. So oxygen is essential for the cellular energy metabolism. And in case of acute ischemic stroke, when the vessel is occluded, the main drivers of the ischemic brain damage is the lack of oxygen. And so when people are not breathing anymore, they will die. The same happens to the cells in the brain. So the number needed to treat should be 1. And the logical step would be to increase the oxygen to the penumbral tissue in order to save it, to rescue it until reperfusion takes place and the natural way of oxygen supply is restored. In the animal experiment, preclinical studies, oxygen was sustaining the penumbral tissue if 4 variables have been met. So the first was that oxygen had to be given at concentrations near 100%. So 70% did not suffice to maintain penumbral oxygenation at a level to keep it alive. Then it should be initiated very early after ischemia onset. In the animal experiments, it was like in the mouse experiment, it was like 30 minutes after symptom onset. Then the ischemia should be of short duration, 3 hours and no longer in the animal experiment. And the fourth aspect was that in order to avoid any excessive generation of free oxygen species, oxygen should be stopped after restoration of the blood flow. This evidence from preclinical studies has not been sufficiently considered in clinical trials so far, but there have been 2 Chinese trials, single-center trials, randomized trials that showed a very strong effect of normobaric hyperoxygenation when it was administered adjunct to endovascular thrombectomy. So this was on one side, the Cheng trial, in which oxygen was administered after successful thrombectomy, and the trial called OPENS 1, which is quite similar to the PROOF study that I will present in the following. They started oxygen before reperfusion, before thrombectomy, for a neuroprotective bridging, and continued oxygen after EVT up to 4 hours in all patients. And there was a massive shift in both trials with improvement of functional outcome on the modified ranking scale at day 90, but there was also a reduced infarct volume, and in the Cheng trial, even a reduced mortality. In the PROOF trial, we wanted to study efficacy and safety of normobaric oxygen compared to standard oxygen supplementation, according to the European Stroke Organization guidelines, in case of oxygen saturation drops below 95%. And oxygen was administered via a conventional non-rebreather face mask with reservoir, and in intubated patients at 40 liters pure oxygen. This would, or the background was to provide enough oxygen flow that even the rapidly, deeply ventilating patient, stressed patient, would not breathe room air. And in ventilated patients, patients received 100% oxygen by the ventilator. We planned 456 patients for this multicenter randomized adaptive Phase IIb trial. And the adaptive design consisted of an interim analysis after 160 patients, which allowed us to stop for either success or futility, which was necessary due to the lack of any real knowledge about the treatment effect in this population. So we aimed at mimicking or copying the animal experiment in which NBO, normobaric oxygen therapy, worked. So we looked for proximal vessel occlusion with a lot of tissue that could be salvaged, indicated by high aspects. We aimed for a short time window and a good pre-morbid state. We had an emergency enrollment procedure with a deferred consent, so patients did not need to sign or consent prior to enrollment. This was possible because oxygen must be applied very early, so there's no time to decide, and the toxicity of oxygen is negligible. Key exclusion criteria were basically complicated stroke cases with CCA occlusion or a dissection or a vasculitis or septic embolism, and respiratory disease that would complicate normobaric oxygen therapy. It was, as I said, two-armed trial. There's one specific thing to mention is that not all patients needed to undergo thrombectomy. They should only be eligible or likely to undergo thrombectomy. In those cases that were not treated by endovascular intervention, oxygen was given for 4 hours, and the same in the control arm. The primary outcome is the ischemic core growth from baseline to 24 hours. We looked for blood gases to get some notion about the pharmacokinetics, but we also looked at the conventional clinical endpoints, such as the early NIHSS and also the classical stroke endpoint modified ranking scale scores at 90 days. Regarding safety, we looked at hemorrhagic complications, symptomatic and any, death and serious adverse events, especially respiratory SAE. This is the enrollment curve. There was one interruption due to safety concerns, more bleeding complications in the NBO arm, and we needed to rule out that there's any relation to the normobaric oxygen therapy, which was not the case, so we were allowed to continue. And after interim analysis was conducted, we reached the 223 patients. The results of the interim analysis were negative. So we had a lower infarct core growth in the control arm, 21 milliliters, compared to 41 milliliters in the normobaric oxygen arm. And the recommendation of the Data Safety Monitoring Board was clear: termination due to futility. We had no safety issues, so we had to, we could continue all the study visits according to the protocol. When looking at the baseline characteristics, the demographics and medical history, became obvious that the control patients were a little bit, or seemed a little bit, sicker compared to the NBO group. On the other side, when looking at the imaging baseline characteristics, such as the infarct core volume at baseline or the location of the vessel occlusion, the NBO arm had more severe presentation, so a little bit larger ischemic core volume at baseline and more proximal occlusion sites and tandem stenosis, most likely reducing collateral flow more than in the control group. When looking at treatment and process times, so both groups received, 2/3 of patients in both groups received intravenous thrombolysis. Over 95% were treated with endovascular thrombectomy, which was conducted in 50% under general anesthesia. Onset to imaging, to baseline imaging, was a little bit more than 2 hours. Onset to reperfusion was around 3 hours, and onset to start of NBO was around 2.5 hours. Looking at the primary outcome in those patients after interim analysis, the result was astonishing because it was just vice versa. NBO group seemed to benefit more of the NBO than the control group. 3 versus 20 milliliters. Before the interim analysis, it was 40 to 20 milliliters. So just the opposite way. Overall, no significant difference. A large scattering of the infarct core growth volumes. No difference, as I said. When looking at the blood gases, yes, we achieved what we wanted to achieve. High oxygen levels in the normobaric oxygen arm. 350 millimeters mercury compared to 108 millimeters mercury in the control group during endovascular intervention. No effect on partial arterial carbon dioxide pressure, and no effect on pH. No critical additional effects beside hyperoxygenation on blood gases, no acidosis, no hypercapnia. And when looking at the change in NIHSS score until 24 hours, similar to the primary endpoint, there was no difference in both groups, where the decrease of a little bit more than 5 points from baseline to 24 hours, no significant difference. And looking at the modified ranking scores at 90 days, again, mixed picture. When looking at the shift analysis was negative. When looking at the modified ranking scale scores of 0 and 1, seemed to be a little benefit in the NBO group. When looking at the dichotomization 0 to 2, it was just the opposite. So these results just indicate that it's pure chance what happened. Most likely too much variability due to endovascular thrombectomy. I come to this a little later. Coming to the safety outcomes, we did not find a negative signal regarding intracranial hemorrhage, but also only a minimal increase of respiratory SAE. Not astonishing when considering that patients needed to breathe this most likely dry oxygen at high flow. Coming to the limitations of the trial, it was an open label study however, with blinded endpoint assessment. Imaging endpoints were all assessed in a core lab. However, we did not have a central reading for imaging before enrollment, meaning that there were some patients who got enrolled with an aspects of 0 with no salvageable penumbral tissue. We have chosen this early imaging endpoint for the reason of less people dropping out due to, for example, withdrawal of care and early death. Then we allowed for heterogeneous imaging at baseline, which favored the routine, or which allowed the routine stroke workup at all centers in order not to delay the standard stroke treatment, intravenous thrombolysis, or endovascular thrombectomy. But on the other side, it generated a lot of heterogeneity when comparing CT perfusion imaging at baseline with MRI at 24 hours. And most strikingly, our assumptions that our sample size calculation was based on were not at all met in our trial. So we used the SWIFT prime patients in whom infarct core growth was described. We derived the mean and standard deviation from the provided median and interquartile ranges. So it was 18 plus minus 21 milliliters. And in our control group, which was also undergoing endovascular thrombectomy plus minus thrombolysis, The mean volume was similar with 20 milliliters. However, the standard deviation was 3 times larger. Instead of 20, it was 70 milliliters. Rendering our assumption for the small sample size not valid anymore. When we would have used the variability that we found in our control group, the sample size per arm would have been 1,200 patients. So much larger trial would have been necessary to provide evidence that there is an NBO effect. So the conclusions and our outlook, we could not show beneficial effects of normobaric oxygen therapy in acute ischemic stroke with anterior circulation vessel occlusion. And we found no safety concerns on the other side. Did we respect all the insights that were gained in preclinical studies that showed NBO to be protective? Yes, we did. So we reached high oxygen levels. We initiated oxygen after onset of only 1 hour and 40 minutes. We had short duration of ischemia of 3 hours and 45 minutes, and we stopped NBO after the end of the endovascular procedure. So what is the conclusion? As I said, the variability was high, and we would aim for a larger future trial. This is supported by our friends' trial in China, the OPENS 2 trial, which has been presented in the same session. They showed a uniform positive shift towards better outcomes, a modified ranking in 90 days in the NBO-treated EVT patients. So very promising results in contrast to ours, neutral results. So they enrolled 290 patients. So only a little bit more than we did. They had a similar workflow. There was one most significant difference, is that they continued oxygen after reperfusion. There's no real evidence from preclinical studies that continuing oxygen after reperfusion is really harmful. But the results did not support a really great additional neuroprotective effect. Basically, when looking at the single center studies, especially the Cheng trial, which only started oxygen after successful perfusion, maybe that's the key. Oxygenation after perfusion. In order to understand this effect, I think we should, we will meet tomorrow on Wednesday for starting a new collaboration with them to perform a patient-level meta-analysis of both of our trials and to really look at the durations at the start, after onset, with regard to brain imaging, et cetera, et cetera. But I can say that the variability, when looking only at the primary endpoint that we have chosen, infarct growth, I would not do it again. So I would keep it much simpler and just aim for the modified ranking and a much larger sample size. Yeah. And the future would be a next trial, large phase 3 trial with many more patients to overcome this great variability. And we're looking for a small oxygen effect of only a shift of 5%. This is important because oxygen is cheap, it's easy to administer, it could be administered worldwide, so no need for high costs. So a small effect would be satisfying for such a therapy. We presented this at the GAINS meeting. GAINS is the Global Alliance of Independent Networks in Stroke Research. And we got very positive feedback and hope for being able to get the funding for this promising future trial, the global PROOF study. So which would be a collaboration with our Chinese friends, and conducted internationally at many more centers as we did in PROOF. Just want to thank my co-workers, young and very experienced, the whole spectrum of stroke research was present, experts in penumbral research, imaging, preclinical, clinical studies, NBO, stroke thrombolysis, etc., reperfusion therapies. And for sure, my team and all the relatives, patients, and investigators who made this trial feasible. Thank you very much.